Hello, I'm Dr. Jim Parise. I'm a small animal surgeon at the University of Florida, and I'm going to cover the small animal surgery section of your licensing examination board review. Today I'm going to focus on three different sections. We'll have just some general topics, and then we'll look more closely into the soft tissue and orthopedic conditions. To start with, suture material. The absorbable suture materials, PDS or polydioxanone, is a monofilament suture, a very similar suture to Maxon, polyglycinate, which is also a monofilament. Both of these will be present in the wound for up to around 6 months. Vicryl or polyglycan 910 is a multifilament suture. This is going to be absorbed much quicker within a few weeks. And Dexon, polyglycolic acid, a multifilament absorbable suture material. And then finally, chromic gut. This is made out of the sheep or cattle small intestinal submucosa, and this is also a multifilament suture. For the specifically, Dexon has been shown to have quicker absorption time in urine, and degradation products have been shown to have potent antibacterial effects. Surgical gut treatment with chromic salts increases the strength and resistance to digestion, and depending on the concentration of the salts, this will dictate how much it does so. For the non-absorbable suture materials, Epilon or Dermalon is nylon. This is a monofilament, and then Proline or polypropylene is also a monofilament. These are probably the most common non-absorbable suture materials used. We also will use silk, which is a multifilament suture material for its handling characteristics in ligating vascular structures, and occasionally stainless steel, also a monofilament suture material. Vetafil or Supermid, which is polymerized caprolactam, is a multifilament non-absorbable suture that is actually been shown to be associated with causing fistulations and infections when used inappropriately. This suture material should not be sterilized chemically. It should either be sterilized with ethylene oxide or with heat sterilization. Features of Proline that are unique is it is the least rhombogenic of the suture materials. It is very inert and has the best knot security of the non-metallic synthetic monofilaments. To establish an infection in a wound, you need to have a critical level of bacteria, and this is generally known to be 10 to the 5th bacteria per gram of tissue. The risk of infection does depend on not only the number of bacteria, but also the virulence of the individual bacteria and also the host resistance. When we classify surgical wounds, we do so in 4 different categories. Number 1 is a clean procedure, and this would be such as a spay where no contaminated organ is incised. Then we have clean contaminated, for example, an enterotomy to do an intestinal biopsy. We have contaminated, and this would be when we have gross spillage from an organ that does have contamination, such as doing a subtotal colectomy and having some of the colonic contents spill into the abdominal cavity. And then dirty is when we are actually incising through normal tissues to get to an infected area, such as lancing of an abscess. Wound healing is divided into 4 different stages. Inflammation is the initial event that occurs, and this is between 12 and 24 hours. This is started by the blood clot and the fibrin seal, and then during the next 2 to 4 days, debridement occurs, and this is predominantly white blood cells, and most importantly, the macrophage, because this will then be the signal cell to send out cytokines to induce fibroblasts to come into the wound to help begin the process of proliferation. And proliferation is going to start around day 3 or 4 and go to up to 3 weeks, and fibroblasts will be laying down collagen. After the 3-week period of time, we have a remodeling or maturation phase, and this is reorganization of the collagen fibers that will strengthen over time. The general recommendations for lavaging wounds are 7 to 8 pounds per square inch. This can be achieved with a 60 cc syringe and an 18 gauge needle, and to do so in a pulsatile manner. When topical antiseptics are used, 0.05% to 0.1% of chlorhexidine is recommended, and this will have minimal inhibition of granulation tissue when used at this dilution. When povidone iodine is used, it is used at 0.5%, and povidone iodine has been shown to be inactivated by organic matter. When considering bandages, we usually do bandage wounds with 3 different layers. We have a contact layer, and this is the first layer. This is going to contact the wound, and we generally either use an adherent or a non-adherent layer or dressing. The adherent dressings will be the wet to dry, dry to dry, or wet to wet bandages, depending on how much wound fluid is exudating from the wound. The wet to dries would be used when we have very little wound fluid and we actually need to introduce some fluid to help loosen up some of the debris that needs to be debrided. And then when we use a dry to dry bandage, basically there's a lot of wound fluid and we don't need to wet the bandage before applying it to the wound because the wound is exudating so much. The non-adherent dressings we only use if we have a nice healthy bed of granulation tissue and we're trying to promote epithelialization without debriding the wound whenever the bandage is changed, because the other adherent dressings will pull off the superficial portion of the wound. Then the intermediate layer is the second layer, and this will be providing absorption and pressure, relief, and also support. And we will also apply pressure to the wound to help with postoperative swelling in some instances. Then we have the tertiary layer, and this is also for providing support and protection and also water resistance. There are a number of different bandages and slings, but to mention a few, the spica splint is used for stabilizing humeral and femoral fractures, at least temporarily. It's impossible to immobilize the shoulder and the hip joints completely, even with this bandage, so it's usually only used as a temporary bandage before primary fixation is undertaken. Then we have the Robert Jones, and this is usually used for fractures below the elbow and below the stifle. A Velpo sling is used to fix the animal's front leg in a flex position, and this we use to treat shoulder luxations and scapular fractures, and sometimes postoperatively to help take the weight off of fixations in the scapula and in shoulder arthrodeses and repairs. Then we have the Schrader-Thomas splint. This is a traction device made with bandaging material and aluminum rods, and this is for fractures that are below the elbow and the stifle. To mention a few drains, we have passive drains. These depend on gravity and capillary action. For an example of this would be the Penrose latex drain. And then we have active drains. These are negative suction drains, such as the Jackson-Pratt or Snyder drains. And these will apply a continuous or an intermittent negative suction to wick fluid out of the wound. And any drain will produce between 1 and 1.5 mils per kilo per day. Perioperative antibiotics, most commonly we'll use cefazolin, a first-generation cephalosporin, and most commonly we're targeting the bacteria of Staphylococcus and Escherichia coli. And periop antibiotics are usually given at induction of anesthesia or 30 minutes prior to the initial skin incision is made. And then the doses of cefazolin are repeated every 2 hours, usually throughout the procedure until the skin is closed. And there's no evidence to prove that using peri-op antibiotics longer than 24 hours after surgery has any benefit in reducing the incidence of postoperative infections. When we culture wounds, we usually, it's recommended to culture a wound before and after debridement and lavage, as sometimes the bacteria identities are going to be different after thorough debridement and lavage, or the bacterial numbers. And we usually recommend aerobic and anaerobic culture and sensitivity. We'll have the best chance of recovering bacteria or growing bacteria when an actual piece of tissue is submitted. This has been shown to be true, especially in the bladder when performing a cystotomy, that culturing the bladder mucosa will yield the most likely growth of organisms over urine, for example. There are 3 different types of wound closures, and then letting wounds heal by open healing or second intention healing. Primary wound closure is, for example, would be just after doing a spay procedure, where we're going to close the wound primarily right after a procedure is performed. We have delayed primary. These are wounds with gross contamination or devitalized tissue that we're not comfortable with closing right away, and we're going to close these on average 3 to 5 days after the injury has taken place or a bite wound has taken place. We have secondary or third intention healing, and these are wounds that have chronic contamination and require a longer time of debridement. This typically would be a couple weeks after wounding, and we've got a nice healthy bed of granulation tissue, and these are commonly closed over a Penrose drain or some sort of drainage from the wound. And then finally, second intention healing is allowing a wound to heal by second intention or open healing, where we don't provide any closure at all. We just allow the wound contraction and wound epithelialization to occur naturally. So now we'll cover some of the specific soft tissue diseases in detail. Cleft palate is a congenital condition, and this is you probably can't see this too well, but this is a photograph of a cat with a cleft palate having primary repair of the actual cleft, and we've done this by incising the edges and elevating mucoperiosteal flaps and sliding them towards the midline. Oronasal fistulas also occur in the palate. These are acquired conditions, and they are sometimes seen with trauma. They can be the result of surgery if we've taken out a section of the maxilla for a maxillary located tumor, and then sometimes with severe periodontal disease, there is a hole left communicating between the oral and the nasal cavity. Salivary mucoceles, most of these will occur in the cranial cervical area or the intermandibular region. You might be able to make out a dog's snout is being lifted here, and we see a very large accumulation of saliva right here in the upper portion of the neck. When the saliva accumulates in the sublingual location, as pictured here, this is called a ranula, and sometimes dogs will have both the intermandibular and the sublingual accumulations. The sublingual salivary gland is usually the gland that is leaking, regardless of whether these collect in the intermandibular, sublingual, or even in a pharyngeal location. It's always the sublingual gland, or in almost all cases, that is leaking, and it is necessary to remove the mandibular gland and the sublingual glands together. Following removal of these glands, we'll then drain the mucus seal by inserting a Penrose drain and allowing that to drain for 3 to 5 days. Different feeding tubes available. We have the nasogastric feeding tube. We have a nasoesophageal, pharyngostomy tubes, where a hole is made just in the pharyngeal region, and then we have the esophagostomy tubes as pictured here. The hole for the esophagostomy tube is going to be a little bit further caudal than where a pharyngostomy tube would be placed, and this has less incidence of obstruction of the larynx than pharyngostomy tubes do. And then we have gastrostomy tubes. Picture of one here. Here's the cat with what we call a low-profile, elastic gastric feeding tube that can be in place for a long period of time. And then finally, jejunostomy tubes, which are indicated in cases of pancreatitis when we're trying to feed the animal and at the same time bypass the stomach and upper portions of the gastrointestinal tract. Okay, for our gastric surgery, most commonly we will be performing gastrotomies, and this will be, for example, take out a gastric foreign body, sometimes with resectable gastric neoplasias, or in doing partial gastrectomies following necrosis from a gastric dilatation volvulus. We're usually going to do either a single or more commonly a 2-layer inverting closure, and I'm not sure if you'll be able to make out these patterns here, but they are pictured in most of the surgery textbooks, where we're going to take bites before and then coming out before the incision and then exiting before we get to the incision, going over to the other side of the incision and then doing the same. So the end result is that the tissues invert, and this can be done either in an interrupted or continuous pattern. There are a couple different surgeries done in the pyloric area. One is called pyloromyotomy, and this is done through the muscular layer only if there's muscular hypertrophy that's causing a gastric outflow obstruction. We also have the Y-to-U pyloroplasty, which is also done for gastric outflow obstructions, but these will be cases that have more of a mucosal involvement as well. And this then requires a full thickness incision. So pictured here, we start with a Y-shaped incision, and then advancing the upper portion of the Y into the lower portion of the Y, the end result is a U-shaped closure pattern that functionally widens the pyloric outflow area. I mentioned gastric dilatation volvulus. It's very important to diagnose this condition that we do. We take the radiograph in right lateral recumbency, because if the stomach has rotated to the opposite side in right lateral recumbency, the pylorus will be outlined by air, and we should not see that, because if the dog is in right lateral recumbency, the pylorus should be close to the table and then outlined by fluid. So when we see a pylorus outlined by air or compartmentalization of the stomach, then we know we have that diagnosis. The 4 different gastropexy procedures that are performed are the tube gastrostomy, which is done less commonly, the incisional, which is probably the most commonly used technique, and then the belt loop and circumcostal. And both these techniques have been shown to be a little stronger than the other techniques, but as long as the incisional is done properly, it's what the majority of surgeons do. Okay, we're going to switch to small intestinal surgery. For doing enterotomies and resection and anastomosis, we'll be doing enterotomies for intestinal biopsies or to remove a foreign body or multiple foreign bodies, such as linear foreign bodies in cats, sometimes require multiple enterotomies. And then in some conditions where we have neoplasia that needs to be resected, or we have a devitalized section of bowel from either foreign body or trauma, then we will have to perform a resection and anastomosis. And this is usually done with a full thickness appositional interrupted closure. Some surgeons prefer a modified Gamby to get better apposition of the tissue layers, but most commonly we'll be using a full thickness closure. And then it's usually recommended to perform an omentopexy to help with any sealing of any leaking that could occur around the anastomosis site, and especially in patients who are immunosuppressed or receiving chemotherapy drugs, serosal patches by suturing the serosal layers of adjacent bowel loops over the closure site and the anastomosis site is recommended to help prevent leaking. The surgery of the colon is always a little more dangerous because you have higher bacterial levels and a lot of anaerobic bacteria. The colon has a segmental blood supply and is in general a little slower to heal than the small intestine. There's high collagenase activity. Colonic surgery is most commonly done with cats with idiopathic megacolon, or we're either doing a subtotal or in some cases a total colectomy. Rectal prolapse can result from any condition that causes excessive straining, and this is usually, we attempt to try to treat this with just manually reducing the prolapse section of rectum and tying a purse string to hold it in, and then trying to correct the underlying problem that's causing straining. If we have non-viable tissue that cannot be reduced safely, then we will have to amputate the section of rectum that has prolapsed and perform a 360-degree anastomosis. If the condition is very severe, we will sometimes also do a colopexy to help prevent recurrence. So I have to do an abdominal incision and go in and pexy the colon to the abdominal wall. Two of the more important anal or perianal tumors, perianal adenomas, we usually see in older intact male dogs, and castration will lead to regression of these tumors because they are androgen dependent. Surgical excision is acceptable as well, but many of them will regress with castration, which is sometimes indicated for other reasons anyway. Also, anal sac apical gland adenocarcinoma we see in, it's usually older female dogs, and this tumor has been associated with hypercalcemia of malignancy. Various procedures to address otitis externa, otitis media. For very mild cases, sometimes a lateral ear canal ablation or a ZEP procedure will be performed, and this will improve drainage and will improve the environment in the horizontal canal. It still does require that the ears are medicated by the owners and cleaned frequently. Ventral bull osteotomy is performed most commonly in cats to remove polyps from the middle ear, or to treat otitis media that does not have an otitis externa component. This picture shows the approach to the bulla in a cat. Can't see it too well, but in retracting the lingual nerve, we then get exposure to the bulla, and we make a hole into the cavity and debride the contents of the bulla with a bone curette. Total ear canal ablation and lateral bull osteotomy are performed to remove contents within the bulla and the entire ear canal. And in this condition, we're going to remove the whole ear canal, so medication of the ear canal is no longer necessary. This would be an example here of a dog that has end-stage otitis externa and probably media, which then we would recommend a total ear canal ablation and lateral bull osteotomy. This procedure is done very commonly. We do see, however, several complications. Probably most commonly is some degree of facial nerve damage, whether it's just a temporary stretching or neuropraxia of the nerve, or whether we have permanent dysfunction. Horner syndrome is sometimes seen because there are sympathetic nerve fibers that run through the middle ear, and with aggressive curetting are sometimes damaged. Hemorrhage has been seen and can sometimes be significant because there are branches of the carotid artery close by. And then sometimes in a low number of the cases we'll see abscess formation that is usually associated with a fistula if we accidentally leave some of the epithelial tissue behind. This most commonly occurs right at the junction of the ear canal to the external acoustic meatus. The brachycephalic syndrome, this is going to be seen most commonly in bulldogs and other brachycephalic breeds, and there are 5 different components. We have stenotic nares, we have the elongated soft palate, everted laryngeal saccules, which occurs as a result of negative pressure within the larynx, and then a hypoplastic trachea. In long-standing uncorrected disease, we will then get end-stage laryngeal collapse. Everted laryngeal saccules are actually the first stage of laryngeal collapse, but when it gets more severe and the arytenoid cartilages start collapsing toward the midline, then the prognosis becomes very poor. So we like to try to correct this very early in life. Tracheal collapse, another very common respiratory disease, usually seen in small breed dogs such as Yorkshire Terriers and Pomeranians. There's a classic goose honk cough, and we can see either the intra or extrathoracic portion of the trachea, or both, be affected. Tracheal collapse is graded from grades 1 to 4 based on the degree of luminal compromise. So grade 1 would have 25% of the lumen compromised. A grade 2, 50% decrease in diameter or area. A grade 3 would be a 75% reduction in luminal area, and then grade 4 would be a 100% decrease where the dorsal membrane is actually touching the ventral portion of the trachea. For diagnosis, most commonly fluoroscopy is performed on the awake animal in addition to radiographs to confirm the diagnosis, and then to better grade it, to determine the grades and to look at the mainstem bronchi, we will perform tracheoscopy before recommending whether surgery would be indicated. We always try to exhaust medical management, but in some cases surgical intervention is necessary when the cases are very severe. Laryngeal paralysis is a result of denervation, atrophy of the cricoarytenoideus dorsalis muscle, and this is innervated by the recurrent laryngeal nerve. It's a bilateral disease, but the surgery is only done unilaterally because doing it bilaterally will predispose the dogs to aspiration pneumonia. Surgery is lateralization of the arytenoid, also called the tie-back procedure, and normally we expect the arytenoids to abduct on inspiration. So this is very important to know as you're doing a laryngeal exam and to determine whether a given dog has laryngeal paralysis. The most common or worrisome complication is aspiration pneumonia after surgery because we've permanently fixed the airway in an open position, making them more likely to take in food contents into the airway. Tracheostomy should be performed between the 3rd and 4th or 4th and 5th tracheal rings. The technique of choice is a transverse tracheotomy or tracheostomy. It can also be done in a vertical or a U-shaped fashion, but most surgeons will use a transverse incision between the rings rather than across them. It is recommended that the tube diameter of the tracheostomy tube should not exceed 1/2 the diameter of the lumen of the trachea. The lateral thoracotomy or the intercostal thoracotomy is done to treat conditions such as lung neoplasia, lung abscesses, or lung lobe torsions. We also can perform a pericardectomy through this approach and ligate patent ductus arteriosus, PDAs, and also ligate and divide a persistent right aortic arch, and that's usually the 4th aortic arch that persists on the right side to cause that vascular ring anomaly. And then also chylothorax, we will approach from from an intercostal approach to perform thoracic duct ligation, which is successful in some of the cases. Lung lobectomies are usually done by either individually ligating the pulmonary arteries and veins as well as the bronchus, but we can also use a special stapling device to do it without ligations. And we can either remove the entire lobe of lung or just a portion of it, a partial lobectomy. Median sternotomies are performed to treat conditions such as neoplasia, like cyanomas, which can be very large and too large to take out through an intercostal approach. Pericardectomy can also be performed through a median sternotomy, and it is the preferred technique if we need to perform an exploratory thoracotomy to visualize all the different lung lobes, such as with spontaneous pneumothorax, where we're not sure in some cases where the lesion is. Access, though, to the lung hilus is difficult, so it is difficult to remove lung lobes from this approach. There's a lot of different types of hernias, and it depends, number one, on the anatomical location. We have diaphragmatic hernias, abdominal wall hernias, usually a result of trauma, and then we have inguinal and scrotal hernias, also perineal and incisional hernias as a result of dehiscence. Some hernias can be divided up into congenital versus acquired, which are usually going to be traumatic when they're acquired. Such as diaphragmatic hernias, sometimes they're congenital and sometimes they're a result of trauma. And then we have, they're classified as either reducible or irreducible. Another term for this is incarcerated. Diaphragmatic hernias are surgical emergencies when the stomach has herniated through a rent in the diaphragm on the left side. Because of gas dilation, the animals become very dyspneic. Different radiographs are done to confirm the diagnosis. If it's not obvious on plain film radiography, positive contrast studies such as a barium series to see intestinal loops in the chest cavity, or even doing a peritoneogram by injecting a water-soluble contrast agent into the peritoneal cavity and seeing if it makes its way through a defect into the thoracic cavity. In general, the prognosis is good if they survive the first 24 hours after surgery. And diaphragmatic hernias that are congenital are usually peritoneal-pericardial hernias, where the contents in the abdominal cavity are herniate through within the pericardium. Perineal hernias, there's a higher incidence in older intact males, and various organs may herniate into the perineal area through the pelvic diaphragm defect or weakening, such as the prostate, very commonly, and sometimes the bladder. Also, the intestines are sometimes found in the hernia. And the herniorrhaphy is performed by suturing the internal obturator muscle that is lifted up as a flap to the external anal sphincter and either levator ani or coccygeus muscles. Portosystemic shunts, in general, small breeds get extrahepatic shunts, and large breeds usually get intrahepatic shunts. Sometimes will manifest, an animal will present with chronic urinary tract infections, and this is often the result of ammonium biurate stones, a classic stone for shunts. And the clinical findings are sometimes seen are abnormal behavior, thank you, seizures and head pressing, various neurological signs. In cats, we will sometimes see hypersalivation and almost pathognomonic. Cats with copper-colored eyes have been associated with portosystemic shunts. So a portosystemic shunt will be any communication, as pictured here in light green, if you can see that close, an abnormal communication between the portal venous system and the systemic venous system. Splenectomies are performed for various reasons, either partial or complete. Almost In most instances, there will be complete splenectomies, especially when we're dealing with a tumor, because we don't want to leave a chance for recurrence. Different other conditions are splenic torsion, ischemia or infarction that is sometimes seen with GDVs, and the torsion of the stomach that also causes torsion of the spleen. And then some of the immune-mediated diseases like hemolytic anemia is sometimes indicated to remove the spleen, and also trauma. Most commonly, the ligations in the splenic vessels are made at the splenic hilus. It is possible to work further down in the main splenic artery, short gastric arteries, and left gastroepiploic levels. But when doing so, you need to be careful not to disturb or ligate the blood supply to the pancreas, the left lobe of the pancreas, which the splenic artery also feeds. Briefly, uroliths. The radiopaque uroliths are two different types: struvite stones, also called magnesium ammonium phosphate or triple phosphate stones. And in some instances, medical treatment of these stones can be successful with dissolving them. They're usually associated with infection in dogs. Calcium oxalate stones, another radiopaque stone. These are metabolic stones that will need to be removed surgically. They're not amenable to dissolution with dietary and medical management. And then the radiolucent stones that we more commonly see are cysteine and urates. In male dogs, stones most commonly will lodge at the base of the os penis in the urethra because it narrows before going into the bony structure. If we are unable to retrohydropulse these stones back into the bladder, either prior to surgery or at the time of surgery, we in some instances have to perform a urethrotomy to retrieve the stone and then relieve the obstruction. And when indicated, permanent urethrostomies are performed to help prevent further obstructions. And in dogs, these are usually done in the scrotal or sometimes prescrotal area, and a prepubic urethrostomy can also be performed when the intrapelvic portion of the urethra is damaged or not functional. And in cats, this is either done in urethrostomies are usually done in a perineal location, but also in a subpubic and prepubic area, again when the intrapelvic or very caudal sections of the urethra are damaged. The common spay-neuter complications we see are hemorrhage resulting either from the uterine or ovarian arteries, wound dehiscence, recurrent estrus, and stump pyometra, both usually as a result of ovarian remnants being left behind, because ovarian remnants are necessary to have a stump pyometra. And then ligation of the ureters happens accidentally in some cases when trying to clamp off a bleeding ovarian artery, because the ureters are in very close proximity to the ovarian vessels. Fistulation is sometimes seen when inappropriate suture material or ligatures are used on the stumps of the ovaries and the uterus. For example, I mentioned the Metafil or the Supermid polymerized caprolactam. When that's not properly sterilized, we'll sometimes see, this is notorious for causing fistula or infections to form that will manifest as fistulous tracts in the flank of the animal. Cryptorchidism is a hereditary condition, so we don't recommend breeding in animals that have this condition, and we need to wait those 6 months before we can say with certainty that a given testicle has not descended, because it can take up to that long to do so. These testicles are associated with neoplasia, and the most common would be a malignant tumor called a Sertoli cell tumor. Cryptorchid testicles can be either intra or extra-abdominally located. Prostatic disease in the dog, there's the surgical treatment for the individual diseases. For BPH or benign prostatic hypertrophy, usually the treatment is castration. This will cause regression of the prostatic parenchyma over a few weeks or a couple of months period of time. And then when we get prostatic abscesses or cysts, they're usually drained either with a multiple Penrose draining technique or a marsupialization technique, and more recently just taking the greater momentum and following drainage of the prostatic abscess or cyst, packing the omentum within the cavity and suturing the omentum in to allow it to be able to drain, provide a physiologic drain for the animal. Prostatic neoplasia treatment is either none if it's too advanced, or if it's not too advanced, sometimes a prostatectomy is performed. This does often cause urinary incontinence. Pyometras can be either open or closed. In the closed pyometras will not be draining very much in the way of vaginal discharge. E. coli is the most common organism, and this is going to be intact females that are in diastrus are going to be the ones that are affected with this condition. Cystic endometrial hyperplasia is a predisposing cause to pyometra, and this often requires an emergency ovariohysterectomy. The old saying, never let the sun set on a pyo. For dystocias, we will sometimes perform cesarean sections. They're indicated when we have uterine inertia, either primary or secondary uterine inertia that's not responsive to oxytocin, or if we have mechanical or obstructive dystocias. And this is usually done by just an incision in the uterine body, a single incision, and then milking the pups down through that incision. It's also important to remove each of the placentas before closure. Closure is usually a two-layer closure, inverting pattern similar to what is done in gastrotomy closures. The different surgical procedures done for mammary gland tumors are the lumpectomy, where we're just doing a marginal excision around the mass. A simple mastectomy, we're just taking the mass and the associated affected gland, mammary gland. A regional mastectomy would be the gland that's affected and the adjacent glands sharing the same lymphatic drainage usually. And then the radical mastectomy, where we're taking an entire chain of glands, as pictured here. We're going from cranial to caudal and getting to the last portion of this tumor here. It's always good to take either or both the axillary and the inguinal lymph nodes for tumor staging to see if the lymph nodes are involved. Ovariohysterectomy has been shown to have a sparing effect on the incidence of mammary cancer in dogs, and this is reduced to, the incidence is reduced to 0.5% when compared to a non-ovariorectomized dog if the stay is done before the first estrus. It increases to 8% if it's before the second estrus, and then 26% if it's after the second but before the fourth. After the fourth estrus cycle, or greater than 2.5 years of age, ovariohysterectomy has not been proven to have a beneficial effect in preventing mammary cancer. So we're going to switch to the orthopedic section now. To start with fracture classification, and we always start by saying whether or not it's an open or closed fracture, such as this tibial fracture. Tibial fractures are commonly open fractures, which is going to definitely affect the prognosis. If it's a complete fracture, such as this, or whether there's, just a fissure or a green stip type fracture where the fissure does not go around the circumference of the bone completely. Then we'll comment on the configuration, whether it's simple, just two fracture fragments, this portion and the lower portion, or whether it's comminuted and that there are many fracture fragments at the fracture site. And then also whether it's oblique or short oblique, such as this fracture, or whether it's straight across, which would be termed transverse. Also the location, whether it's in the diaphysis the metaphysis down here, or down involving the joint in the epiphysis, which is going to be above where the epiphyseal, the physeal scar was located. And the bone involved, which would be, in this case, the tibia and the fibula, and then whether it was the right or left bone. We also comment on the degree or the direction of displacement. So in this case, we're looking at a craniocaudal view of the tibia and fibula, and the distal fragment is what this is named, is what displacement refers to, and in this case, at least from this one film, we can tell that it's laterally displaced. We'd need the other view, the lateral view, to determine whether it's cranial or caudally displaced. The Salter-Harris classification, there's 5 different types. The type 1 is where the fracture occurs. These are all growth plate fractures that affect the growth plate. And the type 1, the fracture is going to go, straight across the physis. And in type 2, it's going to go across the physis for the majority of the fracture, and then it'll head up into the metaphysis to take off a little metaphyseal component. Salter-Harris 3 is going to start in the epiphysis, go into the physis, and then take a turn to head across the physis and leave a fragment out here. And then the type 4 is going to go through the epiphysis, across the growth plate, and then through a metaphyseal component, such as lateral condylar fractures, elbow fractures in puppies, where they get a shearing injury that shears off this portion of the humerus, the lateral portion of the humeral condyle. And then finally we have the type 5. This is a crushing fracture or a compression fracture. Most commonly in dogs, this happens at the distal ulnar physis, and when this occurs, it leads to premature closure, which causes radius curvus and a valgus deformity at the carpus. Okay, the different forces acting on fractures that we need to counteract with our repairs or stabilization techniques are bending, torsion or rotation, axial compression, shear, which would be the case if we had a very oblique fracture. It's going to want to slide past, one segment's going to want to slide past the other, and then distraction or tension. Fracture stabilization, the primary fixation must neutralize all the forces that are acting at the fracture site in order to achieve healing. It's usually or often combined with some sort of adjunctive fixation, such as positional screws or cerclage wires, and these are used to reconstruct or anatomically reconstruct some of the smaller fragments. These adjunctive fixation techniques are rarely used as the primary fixation technique. The types of fracture healings that are very important to know are that we either have primary or secondary healing. In primary healing, this requires rigid stabilization, and this primary healing occurs as a result of reversion remodeling or osteonal reconstruction, and these are the cutting cones where the osteoclasts lead, and following them, the osteoblasts are following and laying down new bone. And with primary bone healing, we don't have a callus formation because the bones are very well opposed and they're rigidly stabilized, so there's no need for callus formation. With secondary bone healing, this will take place when there is motion at a fracture site, or if the fracture gap is larger than 1 millimeter, and we will get a lot of callus formation with secondary bone healing. And this follows the normal process of wound healing, starting from hematoma through granulation tissue formation, fibrocartilage, and then mineralized bone. When we repair articular fractures, we have to make sure we get anatomic reduction and that we get rigid fixation with primary bone healing. This will help reduce the amount of callus formation and any any steps or defects in the articulating portions of the cartilage. Ideally, we're going to want to achieve interfragmentary compression also to help make sure we get primary fixation or primary bone healing. Casting is done only for fractures that are occurring below the elbow or the stifle. Anything proximal to that we cannot adequately immobilize to cast. Transverse, simple fractures are going to be of the radius ulna or tibia. In younger animals will be the best fractures for this repair. We want to ideally not use casting to treat real oblique fractures or highly comminuted fractures that are going to want to have a lot of shearing and will not be able to resist the compressive forces applied. Intramedullary pins are commonly used in fracture repair. It's very important to remember that a single ion pin will not provide rotational stability. So to help this, we'll do what's called stack pinning, and this is where multiple ion pins are used, and that way we do get a rotational stability as well as the bending stability that is provided by the pins. Important to know that you cannot pin the radius without the pin going through into the carpal joint and injuring the articular cartilage. So we don't recommend pinning of the radius. Also, when we're dealing with tibial fractures, it is very important that the pin be driven from in normagrade fashion rather than retrograding the pin from the fracture site up proximally into the proximal segment, because when we drive it retrograde fashion, because of the location of the cruciate ligaments and menisci, they are commonly injured when we retrograde pins. So it's important to normagrade tibial IM pins. The various types of external skeletal fixators are the type 1. Type 1 is going to be comprised of half pins. These are pins going from a connecting bar into the cortical bone, and they penetrate both the near and far cortex of the bone, but they do not exit out the other side of the leg. So there'll be half pins in one connecting bar. Type 2 will be full pins, so the pin's going to go through the skin, through the bone, and out the skin on the other side, and then we'll have a connecting bar on either side of the leg, so there'll be two connecting bars. Type 3 will be a combination of these two types. So we'll have a type 2 fixator that in the craniocaudal plane will have, for example, a type 1 fixator coming in at a 90-degree angle. And these can be tied in together so they're all interconnected. And these would have three connecting bars, one cranially, one medially, and one laterally. Big advantage of external skeletal fixation is that it doesn't disturb the blood supply. So this technique is very good for highly comminuted open fractures that we don't want to risk contaminating avascular segments of bone and resulting in what are called a bone sequestrum. Osteomyelitis that occurs, infection, is most commonly going to be Staphylococcus intermedius, and as I said, a bone sequestrum is an avascular infected piece of bone, and this can also lead to fistula formation. The vascular reactive bone that surrounds the sequestrum that's trying to wall off the infection is termed the involucrum. Okay, bone plates are used in three different ways. They can be used as neutralization plates, and this is just to maintain the alignment of the reconstructed fragments. They can be used to compress fractures that are transverse and completely reconstructed. This is done with a dynamic compression plate or a DCP plate, and the degree of compression per screw that is compressed is going to be 1 millimeter. Also, plates can be used to buttress if we have a big bony defect, such as one after a highly comminuted fracture. We'll use a plate in buttress fashion, so the screws will only be engaging the proximal and distal portions of the bone that are still intact. The size of the bone plate refers to the screw size, and a screw size, such as a 3.5 millimeter screw, that refers to the diameter of the threads of the screw. So it all comes back to the when plates are named for their size, it refers to the thread diameter of the screws that are to be used with that plate. Two different functions of screws, and those are to be either positional, where the threads are going to engage both the near and the far cortex, or screws can be used as lag screws. And with lag screws, the threads are only going to engage the far cortex. Because this can be achieved by either using a partially threaded screw that doesn't have threads on the first half of it, so they won't engage the near cortex when tightened down. Or we can use a fully threaded screw, but we'll have to drill the proximal or the near hole bigger, so at the same diameter of the screw thread, so they don't engage. And the result, when we tighten the screw down, is that a fracture can be compressed by the threads engaging the far cortex, and it being sandwiched between the head of the screw and the threads engaging the far cortex will apply compression across a fracture line. Femoral fractures, the common techniques that we use to repair them are bone plates, the interlocking nail, more recently, as I mentioned, stacked IM pinning, and also external fixators. And they can be used fixators can be used to augment single IM pins as well, to help with rotational stability. In very young dogs, we can get excessive callus formation when we have distal femoral fractures, and so especially when we get secondary bone healing and a lot of callus, sometimes we can get what's called quadriceps contracture or tie down. And if aggressive physical therapy is not performed in the early stages of fracture repair in these dogs, they can end up with permanent extension of the quadriceps muscles and a non-functional limb. Bone grafts provide basically three different processes of osteoconduction, where bone grafts act as a scaffold for ingrowth of new vessels and new bone formation. Osteoinduction refers to the inducing of new bone formation, such as with bone morphogenetic proteins, and these proteins stimulate the production of bone. Osteogenesis basically refers to the cells, such as in an autograft, where a graft is taken from one location in a patient and placed into the other. Some of the cells will survive, and those cells will provide an osteogenic effect because they'll still have the capacity to produce bone. So that would be an autograft. An allograft is a graft where we're taking either cortical or cancellous graft, bone graft from one dog to another dog, and then a xenograft, which we don't use very commonly in veterinary medicine, would be taking that bone graft from another species. Cancellous bone grafts are usually harvested from the proximal humerus. Also, the proximal tibia and the proximal femur are acceptable locations to get cancellous bone. Okay, hip dysplasia, there would be a lot to cover, but in general, you need to know that it's associated with large breed dogs. Most commonly, at least, those are the dogs that are going to have clinical problems. It's important to know the Ortolani sign and how to do that, and that a positive Ortolani sign will indicate that the hip is, that you can subluxate a hip significantly. You only get an Ortolani sign positive if the acetabulum is still has a prominent dorsal acetabular rim, so the sensation after subluxing the femoral head can be sensed as the head is reduced. So this is a process where, to perform the Ortolani test, the dogs are in lateral recumbency. We will adduct the limb toward the midline, and then push it in a dorsolateral direction. will then abduct the limb upward, and as we do it upward, if it has been successfully subluxated when it was adducted, then as we abduct it, it should pop back in. The two different presentations for hip dysplasia are, we see some dogs between 6 and 12 months of age that come in with a very acute signs that occurs from the tearing and stretching of the joint capsule and round ligament, and also some of the initial fracturing that's occurring in the dorsal acetabular rim. Then the dogs that present with chronic pain or later in life, this is usually the result of degenerative joint diseases, the secondary arthritic changes that have occurred over time. Treatment, again, we always try to make sure that medical management has been exhausted before we consider surgery, because many animals can be managed medically or with some weight loss, and some non-steroidal anti-inflammatories. Some of the newer conduit protecting drugs are also commonly used. And if the signs don't resolve, then we'll sometimes resort to surgery. The surgical procedures are the TPO, or the triple pelvic osteotomy, the FHO, or the femoral head neck ostectomy, and the total hip replacement, or THR. The TPO is a procedure where 3 cuts are made, triple pelvic osteotomy, 3 cuts are made, 1 in the ilium, 1 in the ischium, and 1 in the pubis. And a special plate, bone plate, is applied that causes rotation of the acetabulum over the femoral head to improve coverage. This procedure is only indicated, however, if there is no degenerative joint disease, or at least very, very minimal degenerative joint disease present. And this depends. Some surgeons will be more picky about this than others. The femoral head neck ostectomy and the total hip are both salvage procedures in dogs that have very advanced arthritis, that have decompensated and are no longer responsive to medical management. And whether or not we do an FHO or total hip usually depends on the size of the dog. If they're less than 60 pounds, many dogs will do very well with an FHO. Those greater than 60 pounds, it's generally recommended to perform a total hip replacement. Okay, osteochondrosis, or OCD, commonly known, is a failure of endochondral ossification. And actually, I should correct myself, osteochondrosis we call OC, and it shouldn't be confused with OCD, which is osteochondritis dissecans. The difference being you can have an osteochondrosis lesion where cartilage is not properly mineralized, but it hasn't yet developed into a flap of cartilage, as we see when it is termed osteochondritis dissecans. This is usually the large and giant breeds that are affected, and is probably the result of, in addition to genetic factors, can be worsened by overnutrition and possibly excessive dietary calcium. The common locations for OCD are the shoulder would be as pictured here in the, you can just make out a defect here in the caudal aspect of the humeral head. In the elbow, we see it most commonly in the distal medial humeral condyle, and then in the stifle, it's most common in the lateral femoral condyle, and then in the tarsus on the medial trochlear ridge of the talus. Okay, another real common orthopedic condition that one must remember is panosteitis. And panosteitis, it happens usually in dogs less than 2 years of age. It causes a shifting lameness, and the radiographs have a very characteristic appearance, what have been called fluffy intramedullary opacities, as seen here in the ulna, and they tend to be centered around the nutrient foramen. On physical exam, we'll find pain as we palpate the long bones and put pressure on the long bones. And it is a self-limiting disease that if we usually with time and supportive care or pain relief with non-steroidal anti-inflammatories, these dogs will resolve these lamenesses on their own. By far and away, the most common breed is the German Shepherd. Okay, elbow dysplasia, again, young, large breed dogs. This is often a bilateral condition, and there's 3 different diseases that have been lumped into this one term of elbow dysplasia, and they are the fragmented medial coronoid process and osteochondrosis of the medial humerocondyle, and then finally ununited anchineal process. For a dog to be diagnosed with ununited anchineal process, which again the German Shepherd is overrepresented, they need to be older than 20 weeks of age because there is a normal radiolucent line that represents a growth plate in this area, and if they're younger than 20 weeks, we wouldn't expect that to be closed anyway. If they're greater than 20 weeks, or possibly 24 weeks in German Shepherds, and they still see this radiolucent line at the base of the anchineal process, then we make the diagnosis that the anchineal process is ununited. Leg calf Perth's disease, also known as avascular necrosis of the femoral head, most commonly is going to occur in young or toy and small breed dogs such as a miniature pinscher and toy poodles. With this disease we get resorption and then necrosis of bone, and then this leads to collapse of the femoral head and then degenerative joint disease. It is usually a unilateral condition, and most commonly is treated by femoral head and neck ostectomy. And these being very small dogs will do extremely well with this surgery. Conservative management has been reported, but more often than not we'll be taking these patients to surgery. Okay, patelloluxation is most common in smaller breed dogs. When we do see it in the large breed dogs, it is most commonly going to be a medial patelloluxation. Having said that, though, when we see lateral patelloluxation, that is going to occur more commonly in large breed dogs than in small breed dogs. But again, both small and large breed dogs are usually going to be medial luxations. There's 4 different grades. Grade 1 would be a patella that can be manually luxated but is not spontaneously luxating, therefore not causing a clinical lameness. And then grade 2, we have a spontaneously luxating patella that is causing an intermittent lameness, but it is in the trochlear groove most of the time. Grade 3 would be a patella that's usually, actually this is a typo, it is usually, I'm sorry, that's correct. It's usually in the luxated position, but we can reduce it. A grade 4 then would be a patella that we cannot reduce. So again, grade 3, that's correct, that the patella would be, for the most part, is riding outside of the trochlear groove, but we can put it back into the groove, at least temporarily. It just tends to want to pop back out. Patelloluxation treatment, surgery is usually recommended for grade 2 and higher. And a variety of different procedures are a combination of the following procedures is usually done: the wedge recession, trochleoplasty to deepen the trochlear groove, and then a tibial tuberosity transposition, where an osteotomy is made in the tibial tuberosity, and tuberosity is pushed either medially or laterally. Laterally, if it's a medial patelloluxation, and then fixed with a small K-wire in place to move the whole quadriceps apparatus alignment further lateral with medial patelloluxations, and the opposite for lateral. In some instances, anti-rotational sutures, such as those used to repair cruciate ligaments, are employed, and especially if there is a concurrent cranial cruciate ligament rupture, which is sometimes the case with patelloluxation. And then another important part of the procedure to correct patelloflexation is to perform imbrication, or overlapping or tightening of the joint capsule, the redundant portion of the joint capsule that occurs over time from the joint capsule being stretched. For example, for medial patelloflexation, the lateral portion of the joint capsule is going to be stretched because everything has been pulled medially for a long period of time. So we'll have to correct that redundancy to help pull the patella back toward the lateral side to correct the luxation. Cranial cruciate ligament rupture. Approximately 50% of dogs with cruciate ruptures will also have a concurrent tear in the caudal horn of the medial meniscus. So it's very important to assess this at surgery and to treat it by excising the torn portion of meniscus. The diagnosis of cranial cruciate ligament rupture is made with a positive cranial drawer test or a positive tibial compression test. There's a lot of different treatments for fixing cruciate ligament ruptures. Most commonly is extracapsular repair. These are sutures going behind the lateral fibula and then drilled through a hole in the proximal tibia, the tibial tuberosity. These are heavy monofilament sutures such as 80-pound test fishing line or fishing leader to help mimic the action of the cruciate ligament. Also intracapsular techniques such as using a fascial autograft or patellar ligament graft have also been used, although less commonly now. A new procedure called the tibial plateau leveling osteotomy is done as well. This and the extracapsular are probably the two most common procedures that are done today. The TPLO is recommended for very large dogs and does entail making an osteotomy in the proximal tibia and reorienting or revising the actual slope of the tibial plateau to prevent the cranial thrusting of the tibia that's occurring with the ligament rupture. In the past, fibular head transpositions have also been done, but they're not as commonly used today. And then we have coxofemoral luxation, or luxation of the hip joint. Greater than 90% of the time, these are going to luxate in the craniodorsal direction. About 50% of the time, a closed reduction will lead to a successful repair and resolution of the problem, and sometimes an Emer sling is used to help keep the limb in a flexed and keep the hip in a slightly internally rotated position. And then if open reduction fails, or if closed reduction fails, we have to resort to some sort of open reduction technique where we're reconstructing the joint capsule using a toggle pin technique. Sometimes a TPO can be used to rotate the acetabulum further over, and other techniques to help resolve the luxation. So that's all I have. Thanks for your time, and we'll answer questions.